Hey everyone, and welcome to PediaTime. I'm your host. As a pediatrician, I'm really excited to talk about something that is truly the heart of our craft. This is for all of you, whether you're a medical student just starting your peds rotation or you're a seasoned doc who just wants a little refresh. Today, we are breaking down the absolute cornerstone of clinical practice, mastering the medical history.
So, let's kick things off with a number that should really make you pause. 70 to 90%. Just let that sink in for a second. That is the percentage of diagnoses that studies show we can make from the patient's history alone. Yeah, before we lay a hand on the patient, before we order a single lab test. It's an incredible statistic, right?
And look, this isn't just some old-fashioned idea. A study from just a few years ago reminds us that even with all the amazing technology we have, the MRIs, the fancy lab work, this simple act of listening to our patient's story is still our single most powerful diagnostic tool. The tech helps, for sure, but it's the history that truly guides us.
Okay, so that leads to a pretty crucial question. If this skill is so fundamental, so important, how are we actually doing, especially when we're still in training? Well, the data suggests there's a bit of a gap between knowing it's important and actually doing it well. And this is where we see the problem up close. One key study looked at final year med students and found something really interesting. They were pretty good at basic communication, but they struggled with the clinical reasoning part. I mean, look at these numbers. Less than a third were rated good at building a differential diagnosis from what they were hearing. Less than 40% were good at spotting red flags. So what does that tell us? It tells us that taking a history isn't just about asking questions. It's about thinking while you listen.
So, how do we get better? How do we build that clinical reasoning muscle? Well, it all starts with a solid foundation. You need a reliable, repeatable structure that makes sure you don't miss anything critical. This is the science behind the art.
And here it is, the classic framework. We've all seen it, we've all learned it, and it's a classic for a reason. It works. Think of it as your mental checklist. It takes you on a logical path from what brought you in today all the way to their family and home life. Using this structure every single time, it builds a habit of being thorough. And that habit protects you, and more importantly, it protects your patient.
Now, inside that framework, the history of presenting complaint, the HPC, that's where the real detective work begins. This is where we go from just identifying the problem to deeply understanding it. It's an active process, and luckily for us, there are some fantastic tools to help us get it right. And here's one of the best ones out there, especially for any kind of pain, the Socrates mnemonic. It's so much more than just asking, so where does it hurt? This pushes you to break that symptom down piece by piece: site, onset, character, radiation. Every single letter prompts a really important question that adds another piece to that diagnostic puzzle.
Okay, so we've got the structure, the science, but having a great framework, well, that's only half the battle. Once you have the science down, you have to master the art. And this is where we make the shift from a simple checklist to a truly patient-centered conversation.
Just look at the difference here. A clinician-centered question is usually a closed, yes or no question from our mental checklist. Does the pain move? A patient-centered question, on the other hand, is open. It invites a story. Can you describe what the pain feels like? The first one gets you a data point, the second one gets you context, it gets you the narrative, and so often it gets you the exact clue you were looking for.
And a really powerful tool for this is the ICE model. It's about exploring their ideas, their concerns, and their expectations. What do they think is going on? What are they most afraid of? What do they actually hope to get out of this visit today? This is just massive in pediatrics, because you're often managing a parent's worries just as much as you're treating the child's illness. Answering these questions builds incredible trust.
So let's bring it all together. How do we make that jump from being a student who just takes a history to becoming a clinician who truly elicits one? It's really about blending that science and that art together every single day with intentional practice.
So let's just do a quick recap. First, never ever forget that the history is your #1 diagnostic tool. Second, always lean on that consistent structure so you don't miss anything. Third, use tools like Socrates to really dig into symptoms. And fourth, use patient-centered techniques like ICE to understand the human being in front of you, not just their illness. And finally, just remember, this is a skill you never really perfect. You just get better at it with every patient you see.
I really hope this breakdown was helpful. For all the medical students and doctors out there, if you're looking for more deep dives into pediatrics and other essential clinical skills, please come and visit my website at www.PediaTime.com. And of course, if you got some value out of this today, hitting that like button and subscribing to the PediaTime channel would mean a lot.
I want to leave you with one final thought. every single time we take a history, a person is trusting us with their story. That's a huge privilege. So the real question we have to keep asking ourselves isn't just, did I get all the information, but am I truly listening? Thanks so much for joining me on PediaTime.